I welcome you all to this instruction course on pediatric retina. And we have some interesting topics to be covered in this particular course. And we are also fortunate to have here Professor Hassan Matada, who's going to give a keynote address. He is one of the, I have seen his finest videos and surgical skills, and which we have seen in many places, including when we were also in the URETNA, as well as we visited as a society last year, Cairo. First of all, I'll invite Dr. Subhadra Jalali, and she's going to talk to us on familial exudative vitreoretinopathy. Dr. Subhadra, please. And also course disease. Yeah.
Good morning, everybody. So thank you for the opportunity. I'll directly go and talk about the neonatal vascular retinopathy. So unlike the adult vascular retinopathies, where we have many tools to study the retina in terms of FFA, OCT angio, autofluorescence, visual fields, the pediatric retina cases, currently most of us have only one tool, and that is a good indirect ophthalmoscopy. So I think all of us should learn good indirect ophthalmoscopy, and if we have access to a fundus photography, that's good. So the normal vascular retinopathies which we commonly see are ROP, FEVR, and Coats disease. So I'm not talking of ROP today, but what is important is for us to realize how a normal retina in a newborn looks like, how an immature retina in a newborn look like, what is an abnormal retina. So just now somebody was asking, so somebody has drawn this type of retina and written no ROP normal. Whenever you have a normal retina, it should have dichotomously branching vessels. Anything other than that is abnormal and is pathological. So you should not ignore these changes. So you can have, like here you can see the retina had dichotomously branching vessels and then it is looping. So this is abnormal. The beginning of ROP, especially there are some new vessels already there nasally which you may miss. So abnormal vasculature is something of an emergency and should be tackled as such and should not be left alone. So everybody should know what a normal retinal vasculature looks like. I cannot overemphasize that any child who comes with leukocoria or something abnormal where you cannot see the retina needs a detailed examination under anesthesia. For example, this child who looked to have a total detachment, actually behind that leukocoria, half of the retina was attached. And you can have other things like viral retinitis. Never miss out retinoblastoma. Good ultrasound is always required. And there can be infection. So there can be many other things in a child with leukocoria who comes to you in your pediatric retina clinic. So a detailed examination under anesthesia is required in many of these. So coming to FEVR, it's an autosomal dominant recessive or X-linked recessive familial condition. It resembles ROP and Coats, and many of these get misdiagnosed as bilateral Coats or bilateral PHPV or as retinoblastoma and get enucleated. The hallmark of this condition is that it's almost always bilateral, very rarely it's unilateral. It can be asymmetric, as you see here. This eye has a fold, whereas this eye has just little avascular retina, if you see it very carefully. And it has three components which can be in varying degree. Exudative vitreopathy. Vitreopathy is manifested by the dragging, that you see the macula is dragged or the disc is dragged or there are folds, and the retinopathy, which is manifested as hard exudates or new vessels. So these three components can be in varying degree. It happens in both the sexes, so there's no preponderance, and it can have two peaks. One is in infancy and early childhood, and next is in teenage to third decade. It almost always happens in term babies, but there's nothing stopping a preterm baby from having FEVR if they have the genetic mutation. So family history is very important, and there's a variable expressivity, penetration and manifestation. Here you see two cousins whose parents are related having FEVR in both eyes. So we try to see what is the management of these patients and how we grade them. So I'll be going together. So it is divided into 5 stages. FEVR stage 1 is sort of an aborted phenotype. Most of these people remain stable and they are diagnosed because of this little dragging or vitreous condensation. So if you look carefully, then you will notice these changes, that the arcades are little dragged and what we call as supernumerary vessels around the arcade. On angiogram, of course, this can be very well noticed. And this is the father of this 4-year-old child. So you can see that the father is asymptomatic and he's remained asymptomatic for last 20 years. There's been no change in his retina. But the child came with a very severe phenotype of leukocoria since birth in one eye and advanced FEVR in the other eye. In FEVR stage 2, there are 2 basic types. One is the exudative type and one is the tractional type. The tractional type very rarely progresses. Mostly it is sort of, they're frozen in time. Sometimes they do develop reg RDs because of the traction component, but usually they don't develop exudation. And the exudative RDs are the ones which we should diagnose. If they have a retinopathy like an avascular retina or new vessels, then they need retinal ablation. These are less intense and more spaced than what we give for ROP. And always when we do these laser or cryo, we have to evaluate the vitreous and retina adhesions and don't treat in the vascular retina. So whenever there is exudation, then management is a little more tricky because it needs peripheral ablation, but we need to watch out for any increased vitreous traction and condensation, which can lead to various complications of your laser or cryo, like reg-RD, CME, epiretinal membrane, retinal tears, and the exudates migrating into the fovea. So the patient can present just with 1 or 2 hard exudates, as you see here. So that may be the only manifestation that this patient has an FEVR, and then you look very carefully for other signs of FEVR. So this is just to show that this patient with bilateral disease, this is her right eye, 20/40 vision. I have done very little laser, not much, and within 8 months there's a huge proliferation and the epiretinal membrane is so dense. So you can see that, we have missed that there's already a vitreous condensation around the macula, which is causing traction, but there's a huge response to that little bit of laser. And then we had to go ahead and operate. When we operate, we don't do a PVD right up to periphery. We create the PVD up to the area of adhesion, and then we do a broad buckle and we trim the vitreous, because if we try to detach the vitreous all over up to the ora, then we can create a lot of breaks, and this has been shown in literature also. And we could salvage this eye. But her other eye, which actually came with the tractional membrane, I did some cryo and a prophylactic buckle. She improved over 2 years to 2030. The ERM detached on its own. But after 7 years, she lost to follow-up, and then she came with total neovascular glaucoma in this eye from 2030. So it's a progressive disease, it's a lifetime disease, and we have to be very careful of how we are doing the laser. So currently I do laser if there's no vitreous traction, but in a patient like this, where there's a lot of exudation, these things don't work. What you need to do is a careful vitrectomy. Usually I go from the nasal side, enter through nasal ports, because temporally many times the traction is right up to behind the lens. So either you have to sacrifice the lens, or you have to go from nasal side to remove all the membranes and then put oil, and then this disease just completely disappears. So this is another patient, again came with early stage because had leukocoria at birth in one eye and other eye. You can see how the manifestation was totally different. It looked like, it's not FEVR, but when I did the vitrectomy and trimmed that vitreous, then I could see that the whole of the peripheral retina was avascular and we could treat, and after treatment all the hard exudates went away. So what we found was that in our series, the number of children with FEVR phenotype were many, many more than what we saw at older age. So the disease is much more in the pediatric population, although in World Series most of the population is adults. And the stages of FEVR also, most of the patients present in late stage. The interesting thing is that the younger the age, the more severe the phenotype. So they come with detachments in almost 92% of cases when they're younger than when they're older. And they can have associated problems like optic nerve hypoplasia. So in neonates, 2 types of manifestations we have detected. One is a very fulminant type. It almost looks like APROP. So they have very severe phenotype, very immature retina, hardly any retina has formed, and they can present with neovascular glaucoma. Like this 1-day-old child presented with neovascular glaucoma in one eye and vitreous hemorrhage because of FEVR in the other eye. And the other manifestation which we see in neonates is this manifestation. This is the mother, and we are screening the child, and on screening we find the subtle new vessels without plus disease, and this is a very slow growing disease which requires treatment. So these 2 neonatal things we find, and then of course we find a lot of families. This was a family from Bihar. You can see all the children in this family were affected, and 2 of them are in stage 5, and the screening doctor has screened this boy and this one and found stage 2 and lasered, but he didn't screen the father. We screened the father also had FEVR. It's an autosomal dominant disease. All the family members have to be screened and treated. So the genetics in India are still being done out, but there are only 4 or 5 common genes, so we can screen for them and find out the proportion and treat them. So this is just to highlight that previously Norris disease and FEVR are put in different categories, but more and more evidence has come that they are actually part of the same disease. All of them are involved with WNT signaling pathway disease of the retinal vascularization abnormality. For example, this child is a newborn seen by us at 6 weeks. The right eye has a Norris disease type of phenotype, the left eye has FEVR phenotype, and he has an NDP gene mutation. So they are actually spectrum of the same disease, different mutations and different severity. So coming to Coats disease, it's unilateral, non-familial, males are more affected. So very important to rule out retinoblastoma in this group of patients, and treatment is like other vascular retinopathies. But I just wanted to highlight this case. The first time I saw Coats disease in a preemie. So I don't know how prematurity affects Coats disease. So this patient has a normal right eye, very abnormal vessels in the left eye. We treated that at 34 weeks. And then what we found was that over next 6 weeks, new and new vessels and new areas were developing. So it means that whatever VEGF was there, it was actually worsening this Coats disease. And you can see that they don't have any hard exudate. So at that stage, if you diagnose them in the early stage of life, then they don't have any hard exudates and you can get a 6/6 macula. But the disease keeps on progressing. So you can see if you see the baby at 12 weeks, another child, or at 2 years or 3 years, then they come with this dense hard exudates in the macula, which becomes incisipated and calcified, and then they lose their central vision. So I think if we do universal retinal screening, then we will not be getting this type of problem. This was a case which was in a female, referred from Pakistan, was treated there with laser, cryo, and 3 anti-VEGF injections. So people are trying beyond laser and cryo and can be improved. So we have done triamcinolone in a couple of these patients only for the exudative detachment. So the exudative detachment goes away. You still need to treat the underlying retinal telangiectasia, and it responds to triamcinolone. All these big cysts disappeared within, you can see, 3 to 4 months. So very important differential diagnosis that if you have exudative retinal detachment in a child, then you need to rule out certain diseases. If you have bilateral Coats like retinopathy, then you need to rule out certain other diseases. And I'm just showing this patient with Carol Shield showed this looked like Coats disease in a girl, but after a few years, again, this patient came with neovascular glaucoma and diagnosed to have a genetic disorder of facioscapulohumeral dystrophy. This is another disease that we very commonly see, incontinentia pigmenti. So if we see a child of incontinentia pigmenti, this child needs every 2-week evaluation, and if there's a peripheral avascular retina, we must treat it immediately, otherwise they also go into tractional detachment. So that is this fascinating journey of learning the neonatal retinopathies goes on. More and more every year I learn something new about these diseases. So welcome to this field.
Thank you, Dr. Subhadra, for excellent presentation. She has talked about the most difficult diseases too, which we face, and especially the worsening which happens, and we have seen all during puberty and adolescence. Suddenly in fewer cases, they go to many of them. You mentioned neovascular glaucoma and others. We may have some time till later, so we'll go on to, I think Anand wants to present, and then we discuss and we have questions.
So I do prophylactic vitrectomy now in most of these cases.
Yes. They do that. I think he has to go to another hall for a competitive presentation of his paper. So Anand is going to talk to us about interpreting imaging in the retinopathy of prematurity. If we can somehow bring down time to maybe 10 minutes, although it's too late for us, but then we'll have a little more time for discussion. So what I'm going to do is maybe I'll just keep my talk. I think most of the time, since the time I started doing this course, I have never presented this talk, which I always have listed there. So we can do that.
Thank you very much. Thank you, sir. I'll go beyond the standard imaging of RetCam and other imaging because that's being dealt with in other courses. I have no commercial interest. I'm an honorary member for the National Task Force. So these are the headings I'm going to discuss on. SD, OCT, and ROP, ultra-wide field imaging, fundus angiography, at least the new things, OCT angiography, which is the dye-less angio, and finally software analysis in ROP. So let's talk about OCT. Somehow OCT, as adult VR surgeons, we use it every day. We can't think of life without it. But pediatric OCT was not so popular. We know why. There were no devices to do it. Either you have to use the flying baby position or you have to take the baby under anesthesia. But with the availability of the handheld OCT, we've learned a lot. And I want to summarize some of that learning in the past 3 or 4 years. We're all familiar with what an adult OCT should look like. This is a 38-year-old healthy normal male. And this is the outer plexiform layer that comes and fuses with the inner limiting membrane. This is important because you have to see the difference in a baby. Also, you know that at least 4 layers should be seen here. The external limiting, the ISOS, which is nowadays called the ellipsoid zone, the interdigitating zone, which is used to be called OSRP, and the lowest RPE. Now this, in contrast, is a 38-week-old preterm baby. So what are the differences you're seeing? You're seeing that the outer plexiform layer is continuing straight. It's not come and fused with the ILM. So this persistence here of the inner retinal layers is important, and we'll show you why. And when does that fuse, and what happens if it doesn't? The other thing you're noticing here is you don't really see a tent in the ISOS. So the easy layer is just flat, That's because the cones are not tall enough. So when do these layers develop? So we were sequentially imaging these babies. So this is a 38-week-old born at 34 weeks. So it's 4 weeks after birth. Look at the two blue arrows. You'll see them coming closer and closer. This means, so the one white layer that you see at the foveal center is now the RPE. It's not the ISOS. But as the child grows older, with 42 weeks, you can see it coming closer to each other. And this is called the centripetal force, or the centripetal growth. At 46 weeks, it's almost there. At 47, it's there. And at 2 months after term, which is 48 weeks, you now see a double layer. So at this point of time, it is still shallow because the cones here are short. And it's only by 9 or 10 months, or maybe sometimes even earlier, these start looking like an adult. So what are some of the changes we see in preterm babies? This was something that we discovered, at least accidentally. We were trying to do OCT on the ridge and then accidentally found what is now called macular edema of prematurity, or MEOP or MOEP, depending on which journal you submit it to. So this is, we've classified it as two types. Type A is when there is complete disruption of the foveal bend, and type B where there are a few intraretinal cysts. The interesting part of both these types of edema is that it spontaneously goes away by the time the child is about 3 months corrected age. But does this influence vision? That's something we need to see. So that's our pattern A, which resembles a cystoid macular edema of adults, and pattern B, which looks like a less severe form of CME. So what we did is we followed up these babies. We looked at age-matched controls, a group that had ROP but no edema, and then preterm babies who had no edema or no ROP. And we found that they definitely had poorer vision even at the end of 1 year, despite it being a very transient edema of about 8 to 10 weeks. This means that at a critical time of fovealization, some transient anatomical changes can influence vision. What's even more interesting is that we found that these babies with edema, transient, had more hyperopia at the end of 1 year. So we know in CSCR or CSR, we turn a little hyperopic, but the position of the fluid there is much lower. This is intraretinal, inner retinal fluid. So the cause for this hyperopia has been noted to be something else. And what is that? That is the defocus. So at that age, when the near vision, when the only vision the baby can see is maybe 30 centimeters or less, this foveal edema is possibly causing defocus. And defocus does not allow you to become closer to emetropia. A longitudinal British study showed that the normal refractive error of a 2-year-old is slightly hyperopic and not emetropic. So hyperopia is the way to be. And as you're 1 year and 2 year, you should be a little more hyperopic than myopic. If you're already plano, that means you're up there for myopic progression. Now, we looked at a retrospective series of our images in our babies with preterm, and we tried to see which of these layers, where they come late or they don't come or they appear or not, which of them will code for vision. So the first thing we noticed was this inner retinal fusion, which is here fused, was correlating with poor vision. So if you had persistence of inner retina with that layer which you saw in the beginning, then you could possibly end up with poor vision even at the end of 1.5 years. The other thing that happened is this fusion, the centripetal fusion. If it did not happen by the 3rd or 4th month and happened later, you had poorer vision. The OSRPE, which is called the ID layer, if it turned out late, you had poorer vision. So this is the persistence. This is a foveal dip, which can be shallow, and this is the persistence of the external limiting membrane. So just the tip of the iceberg now is some of these layers, if they don't appear on time, seem to be influencing vision as old as 18 months. And Duke University has done even more longitudinal studies, and they have shown that these subtle markers of macular edema are also known to have poor higher mental function. So there's some transient blood retinal brain barrier leakage that's happening that's correlating with what's wrong in the retina with what's wrong in the brain. This is a paper now accepted in IGO where we looked at the expanding spectrum of OCT in pediatric cases, not just for ROP, but where else you can use it. Now let me go to ultra-wide field. We don't have this device. I have to acknowledge Daraj Shah from the Shroff Eye Center who gave me these images. So there's very, very limited literature on ultra-wide field is 200 degrees or maybe 180 plus. So this is from C.K. Patel group in Oxford, and this is our own Daraj trying a baby, again in the flying baby position. So he was able to image a couple of cases in the acute ROP stages, and then he's got many more FEBR cases as well. So this was a baby that was referred to him, and you may argue that you will be able to pick these findings up even on a regular RETCAM or even indirect ophthalmoscopy, but the panoramic view that you get with a 200 degree shows you that there are areas that require retreatment. This is NV that's active and whole of ischemic areas in the periphery as well. And this was the fellow eye that was again, partially treated, and he wanted to show you how the hemorrhage and the periphery can be picked up all on a single field. This is another case of FEVR, slightly older child, so it doesn't come in ROP. So this one is, we know, as a falciform fold, but the fellow eye, he did a wide field angiography on the same device and picked up, as Dr. Subhadra showed, a peripheral, both early neovascularization and a whole lot of avascularity. So let me talk about our experience in using the angio. This is again done on the standard RETCAM. This was a baby who was almost a year old, a year after being injected with half-dose bevacizumab and treated. You might agree that the treatment is not complete. The laser spots could be a little more dense. Remember, this child is 1 year old or 9 months corrected age. Otherwise looks quite quiet. You see some laser spots, and then you see some sort of a vitreal band maybe. We don't know what that is. The left eye shows some vitreal opacity, something floating, but otherwise looks okay. But the angiograph tells you a completely different picture. So these are actually active eyes. And this is what happens in many cases when you give anti-VEGF and they sort of convert themselves to FEVR. So, and if to add it to that, if you've not lasered adequately, then this is going to be active disease. This baby at 1 year of age had 20 by 1,400 on teller acuity. So the vision is obviously low as well. In any case, this case was treated with supplement laser at a 1-year-old baby. We did it under short sedation. We repeated the angiography about 6 weeks later, and we found that finally the leakage had stopped. So there were some of these odd late leakage spots in the end, but otherwise the disease itself had become inactive. What's more important, the fovea, I've not shown that here, but the OCT started normalizing even on the fovea. Now, this is not a case of ROP, but I thought I'll put this in because you can serendipitously pick up other conditions when you're screening for ROP. This was our case report in EJO. This one was it looks too big, but this baby was actually a late referral for ROP. And you saw the hypopigmented cafe au lait spots, and we picked up this white lesion here, which is the hamartoma. Now, what you might miss here is another lesion right here in the right eye and a left eye. Another lesion here. So what we were trying to do was correlate the angiography findings with the OCT. Now the primary lesion in the right eye in this quadrant showed some late leakage, or rather you can call it even staining. And we tried to correlate that with the morphology of the tumor itself. So this is irregular, and I think you might be able to appreciate there is some of a level of VR interface issues here. And our theory was that because this the surface of the tumor is now opened out into the vitreous cavity, there could be some leakage of dye. As against this lesion that was picked up clinically and on OCT but did not leak on angiogram. And that again we said is because of the smooth contour of the inner limiting membrane and no excrescences of the tumor into the vitreous cavity. The third lesion similarly picked up on the OCT a smooth contour and did not leak. So finally our beginner's luck at doing OCT angiography on a baby. This was again held in the flying baby position. This was an AP-ROP that was treated. This is pre-treatment. And after some amount of treatment, we know these cases will need supplement laser on the flat neovascularization. This is detecting that flat and after the flat. But what happened in between is we tried to do an OCT angiography. This is now, we know, a dye-less device that's taking so many roles now in adult VR practice. What we saw here is the flat NVE, and you'll agree that the superficial image here correlates with the en face OCT. What is really interesting is that we were able to look at the deeper extensions of these NVE in the deeper retina, in the outer retina, and this, of course, here is a artifact. It's what they call a shadow artifact, and any white lesion in the deeper retina or the outer retina is a flow lesion. In adult VR, at least, you're not supposed to see anything white in the outer retina. So if you start, Yes, in the outer retina. So if you begin to see white, it's abnormal, and that basically means a flow lesion. So we were able to selectively treat that, and what we found here is the normalization of the arborization of the flat NVE, and then the disappearance of the flow lesions in the deeper retina. I'm trying to say this because by definition, AP-ROP is supposed to have flat NVE. But now, because of newer ways of imaging these NVE, we know now they have deeper extensions. So we possibly should not be calling it NVE, we should be calling it maybe NVC, a neovascular complex, because indeed it has deeper extensions. I'm going to end with software analysis. This was work that we did with IIT Kharagpur. We took basic RETCAM images and played around with it They do some sort of image extraction and then enhance it using some filters. I just want to show you what a clinical application of this. So when the images sometimes are poor and you cannot pick up the NVE, just color enhancing them, it gives you the ability to look at the flat neovascularization. And in this case, what you might have diagnosed as zone 1, and probably rightly so, when you play around with the non-invasive way of looking at the smaller vessels, you can see that some of the vessels, at least the capillaries, have gone to zone 2. Now this changes the complexity. If you can change the prognosis from zone 1 to zone 2, the way you approach this patient, the prognosis and then the outcome itself may change. It wasn't a very large number, it was 13%, but 13% of our babies in this APROP series got renamed from zone 1 to zone 2. Thank you very much.
Thank you, Anand, for a nice talk on imaging, which in fact is something very big for especially all the neonatal and the pediatric retina cases. And you have shown so many newer things. If you have any burning question to him, you may ask, because he has to leave for another hall.
Sir, poorer vision. You mean the babies that we followed up?
So when you say poorer, I think it just means a 1-line difference or 2-line difference. Or
Yes.
really they were poor.
No, it was,
Means
we
they
were looking
still
at
within normal.
2400 and 2670.
Yeah. So it's like little less than normal. It's not like
No,
suddenly
no,
we
no,
need to
it's
worry that they will have.
No. So they seem to, so I didn't stress on that graph, but they showed a very beautiful improvement between the 3rd month and the 6th month. And by 9th month to 12th month, they were almost equal to their counterparts who did not have the edema. So they seem to have a disadvantage anatomically, and then they functionally improve. Sir.
Since you showed that the foveal maturation takes place only by 2 months, the outer layers develop only by 2 months. Even if there's edema, why should it reflect on the final recovery if anyway the maturation has not taken place of the photoreceptors?
That is a very good question, sir, which is why we had to, I only showed you the retrospective data. We wanted to know which layer has more influence on these. So now we have actually started a prospective thesis of one of our fellows. But just to, in that retrospective data, we had a very small cohort who had ROP. And initially the reviewers wanted us to remove that component because of the question you asked. It confuses the reader on what influence these layers versus ROP will have. Finally, we put it in. The numbers were too small to do a sub-analysis, so I don't have the answer. But it seems like those who had ROP, even the layers, if we said the normal range was 3 months, for them they were appearing even later. So we don't know which one influenced why.
Thank you, Anand,
Thank you,
for excellent talk. And we move on to the next talk. I think we'll go on to the talk by Lingam Gopal on managing coloboma with retinal detachment. And after this, we'll have our keynote address by Professor Hassan Mustala. I have a announcement which I've been told to make here is collect your ready reckoner from the kit counter. So I'm supposed to do it twice, once in between and then towards the end.
I would like to thank Dr. Dogra for having asked me to talk on this subject. Since the time is short, maybe I'll have to chop a lot of slides and gloss over a lot of details. I hope you will excuse me for that. So let's quickly go to coloboma-related retinal detachments. To be very brief in the description of a coloboma, it's inferionasally located, frequently bilateral, associated often with microphthalmos and nystagmus, and disc and macula can be involved variably, as is shown in these pictures. In these four, rather, the coloboma is outside the disc, but the disc is also abnormal, either independently colobomatous as seen here, or is a little abnormal itself, like dysplastic disc. While in these, you find that the coloboma is included within the coloboma of the choroid, hence the disc is partly colobomatous. In this, it retains its normal contour and shape, at least in the lower part, while in this, the disc also is colobomatous along with the coloboma of the choroid. You also find that from the study by Dr. Schobert, the importance of the junction between the coloboma and the normal retina. The area of the membrane which continues is called intercalary membrane. So at this junction, as you can see, the inner layers, that is vitreous layers, continue on as intercalary membrane and become fibrotic beyond a point. While the outer layers, that is the ones which are facing the retinal pigment epithelium, they turn back. This is the photoreceptor layer, which turns back and merges with the retinal pigment epithelium. There's sometimes a duplication of the photoreceptors because of this junction. You'll find a double layer of photoreceptors. And this junction was labeled as locus minoris resistentiae, and this has tremendous importance as to the contribution of coloboma in the causation of the retinal detachment. So the variables in the retinal detachments are the partial retinal detachment. You can be present along the coloboma margins very often, and this is shallow and can be tractional in origin without a rhegmatogenous component, wherein just because the intercalary membrane is tough like a fibrotic sheet, it pulls on the margin of the normal retina and intercalary membrane, and the normal retina gets slightly lifted up enough to cause a shallow detachment without a communication being present in the subretinal and sub-ICM space. But it can also turn out to be rhegmatogenous because at some point of time that locus minoris gives way, and then you have a communication between the sub-ICM and subretinal space. And these tend to show signs of chronicity in the form of a lot of pigmentary degeneration. Total detachments could be bullous or shallow. Shallow ones started off as a tractional detachment and slow seepage of fluid without much of posterior vitreous detachment. But then at some point of time, vitreous also degenerates and you find a reasonably elevated retina. And you can have the bullous detachment where sometimes you can have a PVD, and those retinas actually are relatively healthy and do much better in terms of visual recovery than those which started off as a chronic cardia and turned into bullous detachments. So the variables are a retinal break. You can have peripheral retinal break, a break in the ICM, and a break at the locus minoris, which is actually communicating a gateway between subretinal space and sub-ICM space, so to say. So if you have only peripheral break, it behaves like any other detachment without a coloboma, and you manage it as a routine. But you must be conscious of the fact that it's not always possible to be sure that there is no contribution from the coloboma despite a peripheral break being present. So if there's a break in the periphery and a break in the locus minoris resistentiae, then again the retinal detachment is of the normal retina. There's also a variable ICM detachment, but there's no break in the ICM demonstrable. Not demonstrable doesn't mean it is not there, but if you're really 100% sure, and in a given case that there's no ICM detachment, I'll tell you how it behaves when you do the fluid gas exchange. This is just to show that on OCT, you can actually demonstrate the point of communication between the sub-ICM space and subretinal space. If you see this particular section does not show, shows a communication. There's a gap here between the subretinal space and sub-ICM space. While in this particular section, which is just a few millimeters away from this point, you will find there is no communication. It's a closed space. That does not necessarily mean that we vary our technique of surgery. We essentially end up treating the entire coloboma margin because of reasons, again, which I'll tell you a little later. So coming to, if they have only ICM break, you'll find an ICM detachment which does not spill over into the normal retina. Here, of course, there is a role of prophylactic laser around the coloboma. And if you have a break in the ICM, intercalary membrane, and locus minoris, this is perhaps the commonest way a coloboma's detachment presents. Then you find an ICM detachment, which could be variable in its extent, and a retinal detachment beyond. These are in communication with each other. So you can have breaks in all the three places. Now let's go to quickly the surgical technique. We need to be conscious of the fact this is a microphthalmic eyes. The pars plica pars plana is very narrow, so your sclerotomies have to be correspondingly pushed anteriorly towards the limbus. You may end up sacrificing the lens, which is okay, and the role of encircling band is rather questionable. You perform, of course, a total vitrectomy. Now, during vitrectomy, you find that PVD is very often absent, although the vitreous syneresis could be present, which is why there is fluid access into subretinal space. Vitreous is not really detached from the retina. So the detachment can be a rather violent process in these small babies, and because of the violence involved in the detachment of vitreous, you will find that you can actually create more communications between subretinal and sub-ICM space, although originally there was none or maybe one. And hence is the reason why we treat the entire coloboma margin once we reattach the retina, because during your surgical maneuvers, you tend to create more breaks in the locus minoris resistentiae, which you can't really visualize. I'm sorry. So the identification of ICM breaks can be done now during surgery, although preoperatively it may not be visible, but is again not of great import because you're not going to treat the ICM breaks at all. You treat the entire coloboma as it's a huge break and isolate it from the rest of the retina. Now when you do fluid gas exchange, you will find actually the behavior will tell you what you're dealing with. If it's only peripheral break and you just suck out the water from the disc area or colobomatous area without going into subretinal space, you'll find that the retina balloons around the coloboma without extensions into the coloboma at all. The fluid stops short there and it balloons around it. It tells you there is no exit path for this subretinal fluid and there's no flattening of retina taking place. Here you can create a peripheral retinal break. If your original break is too far in the periphery, do a retinotomy, flatten the retina, and even if you don't treat the coloboma margin, you're hopefully okay. But if you have a peripheral break and a break at the locus minoris resistentia, but no ICM break, how does it behave? The retina balloons around the coloboma, and it extends as an ICM detachment, but still it doesn't flatten because there's no exit into the vitreous cavity. But if you have all the three, there is a locus break in the ICM as well, then the fluid automatically gets pushed into the vitreous cavity and the retina flattens without you making an effort to suck out the subretinal fluid. So this tells you that there's a communication between the two. You can actually visualize the communication if you actually go along the coloboma margin and suck the water. There is a role of relaxing cuts in ICM in a few cases, but you must be conscious of the fact that the blood vessels supplying the normal peripheral retina can go actually across the ICM before they get into the normal retina. So if you were to cut blindly, you actually cut the vasculature supplying or draining the blood from the peripheral retina. But you can cut between these major vessels and relax the ICM. This is required in a very few cases where the ICM is so taut that even when you do fluid gas exchange, the air actually goes into the sub-ICM space, and the ICM is able to keep the retina taut and lifted up at the coloboma margin. This is where your retinal laser around the margin may not take up properly, and when you remove the oil, you tend to have a recurrence of detachment. So this is where you try to relax the ICM by either cutting it radially or circumferentially, depending upon the situation. And of course, photocoagulation, as I said, you'd like to use diode laser, especially when there's a coloboma of the disc involved. You try to surround the disc margin with diode laser, which is deep burns, don't produce destruction of the nerve fiber layer, because if you destroy the nerve fiber layer around the coloboma of the disc, the patient will have no light perception at all. And you also continue along the coloboma margin and along the retinal ora serrata, because that is where you can have small chinks of dialysis occurring because of the fact that there's a relatively narrow pars plana epithelium, and you may have caused a lot of vitreous pull and push during the vitreous surgery, and small chinks of dialysis can go missing your attention. You may not treat them during surgery. When you remove the oil, they are the cause again for recurrences. So silicone oil is preferred because you want to circumambulate the entire coloboma margin, but where there's a partial detachment, you're clear about the vitreous detachment, which is occurred smoothly, you are justified in using gas as well. Silicone oil removal, at the time of removal, you have careful evaluation of the coloboma margin for any area of elevation, and these could mean around the margin of the coloboma as well as in the periphery. You carefully evaluate ICM as well for a pocket of fluid, and even if there's a pocket of fluid in the ICM, if the coloboma margin is well anchored, it's of no concern. When you remove the oil, it stays as an isolated pocket. You carefully evaluate the periphery of the fundus as well for any unidentified chinks of dialysis, and if need be, add additional treatment. And there's almost a 10 to 33% recurrence of silicone oil removal depending upon how diligent you are during the first surgery and during the oil removal. So the causes of recurrence, one is incomplete vitrectomy, if you've not done a good vitreous detachment, inability to produce adequate retinopraxy around the coloboma, PVR, and ICM detachment that dissects through into subretinal space across the laser barrier once the silicone oil is removed. This is where, as I said, the ICM is very taut, and you may have to relax that ICM, okay? Leak from the edge or coloboma because you did not do an adequate laser around the same. Prophylaxis of the fellow eye if the coloboma is a controversial question, because in a attached retina, when you are producing burns with a green laser, there's always a risk that your burns can be full thickness burns, and you can actually cause problems. And these are eyes with nystagmus, and doing them in the outpatient department is very difficult. With indirect laser, you've got less possibility of titrating your burn than with a slit lamp laser. So all these you must keep in mind when you treat a coloboma prophylactically. If the disc is outside, like type 1, 2, and 3, pretty safe. You can just treat the coloboma margin without any risk involved. But in types 4, 5, and 6, I would be very cautious in treating prophylactically. Thank you very much for your attention. I think I finished in 11 minutes. Thank you.
Thank you, Dr. Gopal, for excellent talk. I think we always learn so much about coloboma, retinal detachment from him, which he taught probably the entire ophthalmic community across the globe. And we'll have questions later. May I invite now Professor Hassan Martada, who's a guest speaker with us here. He's going to talk to us on extensive ILM peeling in complicated pediatric rheumatogenic retinal detachment. Professor Hassan Martada is a professor of ophthalmology in University of Cairo. He was president of the Egyptian Vitreous Retina Society, and as I already told you earlier, we've been associated with their group where we invited them twice over to our Vitreous Retina meeting, and their course which they hold was very well taken up. Dr. Hassan Martada. Yeah.
Thank you, Dr. Mangat. It is really a pleasure to be a part of this distinguished meeting. It's my second time here in Jaipur, and I really enjoyed my stay here among friends and making new friends. My talk is about combining vitrectomy with extensive ILM peeling in complicated pediatric rheumatogenic retinal detachment, and the objective is to determine whether vitrectomy and extensive ILM peeling extending to or beyond the equator would help in reducing the post-operative proliferation and reduces the PVR formation, and this may be associated with a better long-term anatomical and visual results. The study included 79 eyes with pediatric rheumatogenic retinal detachment that underwent the vitrectomy and extensive ILM peeling. The age of the patients ranged between 4 and 16, and this is the type of disease entity included: congenital myopia, trauma, post-intraocular surgery, mostly cataract surgery, Stickler syndrome, regressed ROP, congenital globoma, congenital retinoschisis, ophthalmos-Marfan syndrome, and Down syndrome. Well, I believe that buccal has no role in these cases, and when needed, partial lensectomy or phaco combined with posterior chamber intraocular lens implantation depending on the age. Unimanual or bimanual peeling of the adherent posterior hyaloid, and we use brilliant blue assisted peeling of the internal limiting membrane over the largest area possible with or without PFCL. And then PFCL is injected to stabilize the posterior retina, and we do meticulous shaving of the vitreous base. Retinotomy, retinectomy, when needed, is performed sometimes with removal of the subretinal strands. Endolaser was applied for 3-6 degrees, and direct PFCL silicone oil exchange, and then silicone oil was removed after 3 months. Let's have a look on the cases. This is a case of regressed ROP that was complicated with retinal detachment. And as you see, the posterior hyaloid can be peeled, but this can only be done over the posterior pole, and we try to extend it as far peripheral as possible. Without the use of PFCL, we start the ILM peeling, starting with a Tano scraper to create an edge, and then the ILM is peeled under PFCL as much as as much as wide as possible, reaching to or beyond the equator. And this is the post-operative picture. At the time of silicone oil removal, the retina is attached, and we got only this amount of proliferation outside the area of the internal limiting membrane peeling. Again, this is the case of Stickler syndrome, a case with a strongly adherent posterior hyaloid. I tried to do the posterior hyaloid peeling unimanually, but after some time I realized that it is impossible to perform posterior hyaloid peeling only with one hand. So PFCL was injected to stabilize the posterior pole, and with the use of two forceps, the posterior hyaloid was peeled from the posterior retina, extending anteriorly as far as can be safely performed. And this is continued until we could remove most of the posterior hyaloid. And I think this technique should be tried before giving up that the posterior hyaloid is strongly adherent and cannot be removed. And then again, under PFCL, some of the adherent posterior hyaloid was removed also with the use of bimanual approach using 2 forceps and helped by the stabilization offered by the PFCL, the posterior hyaloid, or you can say it is an epiretinal membrane or adherent posterior hyaloid, was removed. You cannot do this with one hand, and if you go to the periphery, we found that there are multiple retinal breaks. Then PFCL was removed to apply the dye, and then without the use of PFCL, the internal limiting membrane again was peeled as far peripheral as could safely be done. Sometimes you have to augment the brilliant blue staining of the internal limiting membrane in order to have a better view of the eye lamp, and this helps to help you to peel it as far peripheral as possible. Base vitrectomy is mandatory, and it should be done meticulously. And as you do the base vitrectomy, you should also try to peel the posterior hyaloid as far peripheral as possible. This is the case of Stickler syndrome. Again, it is not impossible to remove the internal limiting membrane in spite of the high myopia. The injection of PFCL decreases the contrast, so that you have to stain the internal limiting membrane properly before reattaching the retina using PFCL. And as you can see, working meticulously and tangentially, you can peel the internal limiting membrane as far as you can, and this is the picture at the time of silicon oil removal. Proliferation occurred outside the area, again, of internal limiting membrane and could be easily removed and the retina remain attached. This is the case of severe Stickler syndrome with a 360-degree giant retinal break. First, and PVR. First, we have to stabilize the posterior retina, and again, bimanually, I tried to peel the adherent fibrous tissue that causes wrinkling of the edge of the giant tear, and then this area cannot be relaxed except by excision. So a heavy diathermy is applied, and with the use again of bimanual forceps in one hand, the cutter in the other hand, so as to perform controlled excision of the contracted edge that is beyond any repair or any flattening. So this is continued till the contracted edge is removed, and again working on the other side, removing the contracted edge until the circumferential contraction is removed. Again, more PFCL is injected and then removed to inject the brilliant blue, and the internal limiting membrane was extensively removed as much as possible. And this is the picture at the time of silicon oil removal with the posterior retina stable. Some proliferation occurred at the far periphery that could be easily removed. Again, this is the case of type 2 Stickler syndrome, and you can see the beaded appearance of the vitreous fibrils. The posterior hyaloid was easily removed, not like the previous cases, and internal limiting membrane was removed, and we followed the same technique. Again, this is the case of optic disc coloboma or morning glory syndrome, and the posterior hyaloid was very easily removed, and the internal limiting membrane again was removed first without the use of PFCL, and then under PFCL, and then laser was applied around the coloboma, and this is the picture at the time of silicon oil removal. A case of Marfan syndrome, the technique was the same, removing the internal limiting membrane, but this patient developed recurrence, but the posterior pole was free of any proliferation, and there was an inferior recurrence. I made a retinotomy to relieve the traction, and then laser was applied. This is the case of congenital retinoschisis, and you can see excision of the inner wall, and this is the vessel connecting the inner and the outer wall. Again, the posterior hyaloid was very easily removed. So the orthodox teaching of difficulty of removing the posterior hyaloid in the pediatric age group should be revised, because you cannot determine the difficulty except when you are inside the eye. And this is at the time of siliconoid removal, again, proliferation is away from the posterior pole, so the function of the posterior pole is preserved. ILM peeling could be peeled at least over the posterior pole in all cases. None of the eyes developed recurrent epiretinal proliferation over the area of internal limiting membrane peel. Recurrent epiretinal proliferation outside the area of ILM peeling was encountered in 58 eyes. Recurrent proliferation always stops at the edge of the ILM peeling. Recurrent detachment with or without PVR occurred in 12 eyes, and stable attached retina following siliconoid removal was achieved in 91 eyes. Let's have a look on this case. This is a case of congenital myopia and severe giant retinal break and a severe PVR. The same rules was applied. But look, this has occurred after 4 weeks. We have a severe PV recurrence with severe PVR, but when you look into the macular area is preserved, and there is no proliferation over the macular area, and the proliferation could be removed, and the retina could be attached, and the eye is stable. So, although technically challenging, ILM peeling is safe and effective technique in this age group. It offers effective prophylaxis against epimacular proliferation, improved long-term anatomical and functional results, even when reoperation is needed, no permanent adverse effect on the visual function corresponding to ILM peeling has been noticed, reduced number of operations to achieve final visual attachment. Well, this is the last year, and we have the pleasure of the Vitreous Society of India to have a symposium in the Egyptian Vitreous Society meeting, and invite you all to attend our next meeting in April. Thank you for your attention and patience.
Thank you, Dr. Hassan, for an excellent talk and showing us excellent surgical video as always. Is there any comment, Dr. Gopal, anything you would like to? Subhadra? Anji.
Why? Why not a band? Well,
1 year or 2 years.
The concept of the band, we have to discuss this in details, because this is not only for the pediatric age group. When you are doing vitrectomy, you can release the traction from inside. And I don't believe that doing a buccal can help in reducing the traction and reducing the proliferation or the new tear formation. This is applied to all age groups. So I don't believe that putting a band will help in increasing the visual or the anatomical results. This is one point. The second point is that where you intend to put the band, we usually put the band at the posterior border of the vitreous base. Can you tell me where is the posterior border of the vitreous base in this age group? You cannot. So you are putting the band in anywhere. And I don't believe in anywhere. I don't believe in blind procedures. So I don't feel and I don't believe that putting a band in these cases would add to the anatomical and the functional results. This may be contrary to the general belief, but I have been practicing this since the last maybe 5 or 6 years, not putting a band as long as I'm doing a vitrectomy, and I don't feel that my results are inferior to others putting a band.
Thank you, Hassan. Thank you. We move on to the next talk, and the next is going to be on the persistent fetal vasculature syndrome by Dr. V.R. Saravanan.
Thank you, sir. Just filling in for Dr. Para, who could not make it to the conference here. Sorry for the delay. Persistent fetal vasculature is a congenital disorder where fetal vasculature persists and fails to undergo normal programmed involution. And it can be quite subtle in some patients which you see normally, or it can be quite profound, causing significant vision loss where surgical intervention can be needed, or sometimes even after surgical intervention you don't get the required visual outcomes. So the fetal vasculature comprises of two components, the tunica vascular lentis anteriorly and the hyaloid system posteriorly. As you can see, this is the anterior division as well as this is the posterior divisions of the tunica vascular lentis, which cover encompasses the lenticular structures. So hyaloid system, also called the primary vitreous, they extend from the inferior part of the optic disc towards the surface of the lens at around 4 to 5 weeks of gestation, and this go on to because of process of both phagocytosis and apoptosis, tend to regress and later on filled by the secondary vitreous. So because of the pathology in these structures undergoing involution, persistence of hyaloid can be seen in almost 3% of the full-term infants and almost 95% of the premature infants. And the disorders can encompass Mittendorf's, the spectrum encompasses Mittendorf's dots, Burgmeister's, as well as vitreous cyst and the persistent fetal vasculature. So Mittendorf dots is nothing but a remnant of the anterior fetal vascular system. It's seen at the site of anastomosis of the hyaloid artery and the tunica vascular lentis. It's seen usually in the infrasynaptic quadrant and usually has no significant visual deformity. Burgmeister's papillae can be seen as a remnant of the posterior part of the hyaloid artery as a small fibrous tissue attached to the disc, and again is usually visually inconsequential. Vitreous system can be because of the abnormal regression of the anterior or the posterior hyaloid vascular system, and again is usually asymptomatic and does not cause any visual symptoms. The PF system, the persistent fetal vascular syndrome, can be seen usually seen unilaterally in almost 90% of the people, and approximately around 10% can be bilateral. And most of the time, what we see is non-progressive, but it can lead to progressive visual loss because of the tractional effects on either the antistructures like the lens and the ciliary body, or on the retina. So initially this went by the term as persistent hyperplastic primary vitreous, and later on Goldberg proposed this term to encompass all the changes, deformities which include the hyaloid vessels as well as the tunica vascular lentis, and this is the more accepted form terminology used nowadays. This can be either anterior, posterior, or mixed, and the anterior mainly the remnants of the tunica vascular lentis, posterior the hyaloid component, and you can have a mixture of both as well. So anterior, this is mainly the representative. It can be unilateral and can have microphthalmos usually. Sometimes this can lead to, rarely can lead to ophthalmos because of secondary glaucoma. But what you usually see is the microphthalmos. It can lead to progressive traction, lenticonus, and cataract, or it can present as a thick membrane just behind the lens. And you are doing peeling, you cannot peel it off the lens, so you have to sacrifice the lens in these patients. It can lead to progressive shallowing of the anterior chamber and cause glaucoma, or it can cause traction of the ciliary process leading to hypotony, which is more difficult to manage. Posterior persistent fetal vascular syndrome, posterior part, mainly you can see as microphthalmos may or may not be present. It can have a minimal lenticular opacity, usually off-center, and usually does not cause much of a visual significance. And you can have folds on the posterior pole, or which can present as a temporal falciform fold also. Also, apart from this, it can lead to tractional detachment. Also, there is the deformities of both the optic nerve or the macula. What clinically maybe look very inconsequential may have progressive or very profound structural abnormalities of the macula, leading to poor visual prognosis even after surgery. This is showing sometimes they can be present with other anomalies like morning glory syndrome also. In mixed type, you can see the presence of the changes in both in the posterior part as well as the anterior part. You can see the attachment to the lens, and you can see sometimes the progressive pigment changes where the tractional detachment is there, and this can sometimes indicate very poor prognostic factors as regards to the vision postoperatively. So traction can occur in the ciliary, can lead to progressive change in the ciliary process. It can result in permanent damage or ciliary detachment leading to progressive hypotony, or the lens leading to cataract and lenticonus. So all these things can be seen, And mainly diagnosis is based on the ultrasounds, but sometimes it can be so thin it's easily missed on cursory examination. So you have to be very careful in patients presenting leukocyte in young patients, and always look for calcification, which can be a significant factor in diagnosing retinoblastoma. Any calcification should alert you to the diagnosis of retinoblastoma. Sometimes it can be missed and lead to poor prognosis. Bad after effects if you undergo surgery in these patients. So EVEP seems to be the best way to assess the postoperative visual outcome in these patients. Other things which can be used to rule out other intraocular tumors like MRI in young patients. CT is usually best avoided in very young patients because of the after effects of radiation. OCT, if the visual pathway is relatively clear, can be performed to look at the morphological changes in the macula, whether they are developed well or not, and again may lead to better prognosis if they are well developed. So always these things have to be kept in mind in any patients with the white reflex. All these things have to be ruled out before you go on to operate in these patients. So management will be decided on the appearance, whether there's any progression because of the tractional effects. So you have to look at both the antersegment appearance, the globe size, the lens involvement, vascular appearance, and also the other eye structures, whether operating on this eye is going to relatively really have any betterment as regards to the quality of life index in these patients. So sometimes the visual appearance may not always be correlating with the functional outcome, so you have to look at that as well. So these are the factors to keep in mind when you are planning to operate on these patients. So the ocular anatomy is definitely different when you're operating in these very young patients. So when an anterior disease, you have to mainly sacrifice the lens, cut the posterior, the opacity in the posterior capsule, and then cauterize the vessels which are there. Sometimes the presence of cartilage may need removal through the limbus, like a cataract surgery. Posterior, if surgery is not needed if there's no significant visual these things, but if you're going into the vitreous to clear the extraction, make sure that you first bisect the addition between the lens and the retina, otherwise traction can induce lens damage. So you have to enter quite anteriorly compared to your routine vitrectomy. So you have to look at the possibility of retinal vessels coming into the stalk, and sometimes cutting without realizing this can lead to ischemia of the retina. So they should be very careful to assess whether the normal vessels are migrating into the stalk, and if you're not sure, better to leave a large stalk without damaging the normal vasculature. So this is just a small retrospective study of our patients with 15 eyes of 13 patients in the last 10 years. Predominant anterior we did not see because most of them are taken care of with the anterior segment people, so we only saw in the pediatric retina department around all were mostly predominantly posterior, and mixed type for approximately 13. So we had around bilateral in around 15%. Again, right eye and left eye are equally affected, both equal, almost similar distribution as regards to sex. And age, mean age of diagnosis was around 7 months. And we are around approximately, this is about 84% of the people presented with leukocoria. The defective vision presentation was around 7%, and squinting was around 7%. So 8 eyes underwent surgery, only lensectomy and anterior surgery, whereas combined surgery was needed in 5%, and posterior lens sparing was done in 2%, 2% of the eyes in this study. So final visual outcome ranged from 618 to PL, depending upon the amount of retinal damage. This is a short video showing this patient presented with the persistent vitreous hemorrhage and slightly altered reflex. And after doing the primary vitrectomy, we were able to identify the stalk. So there was a doubt in the ultrasound when you are doing the B scan, and you can see the stalk after the things are cleared. And that's where we stopped to prevent unnecessary damage to the retinal vasculature. So when you operate on this eye, you should remember that surgery alone does not constitute management. You have to aggressively treat the amblyopia present. And sometimes dense amblyopia may not be treatable in these eyes. And also the chance of glaucoma, and especially hypotony is not that very common, but glaucoma is quite common. You have to look out and manage these factors in the postoperative period. Thank you.
Thank you very much, Dr. Samanan. We move on to the next talk, and we'll have time for discussion later. So the next talk is going to be by Padma Malini, and she's going to talk on the pediatric and neonatal uveitis. Dr. Padma Malini.
Respected Chairperson and your friends. Good afternoon to all of you. I'll be talking to you on pediatric and neonatal uveitis. Pediatric uveitis deserves a special consideration because there is delay in the consideration due to the paucity of the symptoms and inability of the children to identify and express the visual symptoms. Most often we find it difficult to examine them, and the inflammation is frequently chronic, and they develop complications secondary to the treatment, such as secondary to the corticosteroid therapy, or they develop amblyopia. The more general belief is that they say that the parents, they say the child will outgrow it. The eye drops are sufficient, so they try to avoid the oral medications, and it's just the eye, so systemic therapy may not be necessary. They hesitate to start the patient on treatment. The approach to pediatric uveitis is similar to adult uveitis, where we do a detailed ocular examination, then naming, systemic evaluation and meshing, order relevant investigations, and appropriately we manage these kids. Neonatal or the infantile examination, where we can do a visual acuity assessment with appropriate teller acuity cards, or handle slit lamp examination can be used to see the kids, and have accessibility to do the imaging. With the handheld OCT and the fundus camera, we can do the fluorescent angiography and allied procedures. Most of the times, we need to spend time with the child and make the child comfortable. Once they develop the confidence, and then they cooperate. They can be like angels, and they cooperate better than adults in many times. We'll move on to the case examples. Here, a 7-day-old male child had history of abscess in the right hand, following which they noticed the whitish discoloration in the eye. The child has endogenous endophthalmitis. We did the AC tap, found to be a gram-negative bacilli in spite of the intravitreal antibiotics and paspana vitrectomy and the lensectomy, followed by systemic antibiotic therapy. The eye went into phthisis. Most of them, they behave aggressive course. Here is a 3-month-old child presented with history of fever. On evaluation, we could see the retinal vasculitis, the patchy sheathing of vessels in both eyes. On evaluation, child found to have a UTI secondary to E. coli, which was sensitive to amikacin. Following intravenous amikacin therapy, we could see complete resolution of the vasculitis in this child. Here is a 2-month-old child presented with redness, history of redness. On eliciting the history, there was a history of trauma. This was hyphema with traumatic uveitis in this child. On systemic evaluation, if the child has joint pain and swelling, most of the time associated with JAA-associated uveitis. Here is a girl who has rashes in the hands with anemia, leukopenia, is found to have SLE. Folks, heterochromic iridocyclitis, most often underdiagnosed and overtreated. It's mostly associated with viral infections. The toxoplasmosis is the commonest cause of infectious posterior uveitis all over the world. They have classical punched out appearance in the macula in a case of congenital toxoplasmosis scar. The choroiditis, multifocal choroiditis can be secondary to tuberculosis, or exudative retinal detachment can be present in secondary to VKH and also sympathetic ophthalmia. Here we can have a rod spots. It was secondary to acute lymphoblastic leukemia, this child. Here is an 8-week-old child suspected to have a cytomegalovirus pneumonitis. Fundus examination revealed 3 discrete well-defined choroiditis lesions in the right eye, 1 ill-defined lesions in the left eye. On evaluation, not only the child, the mother is also found to have an active tuberculosis. Following treatment, 3 weeks later, the child developed a cold abscess. Here is an OCT, shows hyperreflective echo in the outer retinal layer with well-defined lesion, choroidal granuloma. Following treatment with ATT, we could see the complete resolution of the granuloma in this child. Here is a 2-week-old male child referred to us for the nodular lesions in the eye. Ultrasound shows medium reflective lesions in the ciliary body region. The enucleation revealed it's a medulloepithelioma. Here is a 6-year-old child diagnosed to have acute lymphoblastic leukemia with multiple infiltrates on the iris. AC tap shows leukemic cells. Following treatment with steroids and chemotherapy, we could see the resolution of the iris infiltrates. So most of the times we have decision to trait, whether the uveitis is active or quiescent, is infectious or non-infectious, or is associated with systemic disease, and whether the child has any associated complications or not. The corticosteroids is the mainstay in the treatment, followed with cycloplegic agents associated anterior segment inflammation. If the inflammation persists for a longer time, we switch over to immunosuppressives, and conditions like JAA and Behçet's, we do start the child on biologicals therapy. Steroids can be given in the form of topical steroids, intravitreal. Steroid implants also can be given, but sometimes the kids can develop hypotony, followed by systemic steroid therapy. Either it could be oral or intravenous. These kids can develop complications, Cushingoid features. In the ocular, they can develop cataract and glaucoma. Long-standing cases, they can develop band-shaped keratopathy, or severe ischemia can be present with iris neovascularization or choroidal neovascular membrane. Here is a case of a heel toxo scar with CNVM. Here is a 47-year-old male infant diagnosed of active posterior uveitis. On investigations, toxoplasma came positive. CT brain was normal. The child was put on antitoxoplasmic treatment for 1 year, and systemic steroids were given for 6 months, following which we could see the complete resolution of the retinitis in this case. Here is a preterm child presented to us with 1,000 grams in 31/1/2006 and had multiple systemic issues like respiratory distress syndrome, bronchopneumonia, acute kidney injury, and PDA, had persistent thrombocytopenia and ROP. The child evaluation, ROP stage 3 with zone 1 with plus and popcorns, underwent FFA and laser, following which the laser photoregulation was done. Subsequent follow-up was normal. On 21/6/2016, on routine evaluation, we did notice there is a retinal opacification with hemorrhages in the temporal retinal periphery in the right eye and also in the infranasal quadrant. The similar findings were seen in the other eye as well, the retinal opacification with vitreous opacities and vitreous condensations in the inferior retinal periphery. Clinically, the picture looked like an ARN kind of a picture. When we evaluated, the CMV titers were positive. When the child had persistent thrombocytopenia, at that time child had a CMV infection, was managed conservatively with platelet transfusion. So when we did the PCR from the serum, negative for HSV and VZV, the CMV came significant copies of 150 copies per ml. We advised the admissions and intravenous ganciclovir therapy, but the patient's father is a doctor and the neonatologist, both of them, when the child had an active infection, only we managed symptomatically, so they were not keen on. So finally, we made the local pharmacy to prepare the oral preparations. We started the child on oral ganciclovir therapy, following which we could see the complete resolution of the peripheral retinitis in this child. Even though ARN due to CMV infection has been reported in adults, but no reports are there in infants. Here is a 13-year-old male presented with redness and watering associated with joint pain, was treated for allergic conjunctivitis. I'm really sorry about the poor quality of the images. It's episcleritis and scleritis component was there. We suspected vaginous. Cianca was positive, and renal biopsy showed a fibrinoid necrosis with a glomerular crescent, confirming the diagnosis of microscopic polyangiitis. The child was put on methylprednisolone followed by cyclophosphamide infusion, and complete resolution of the inflammation was there. So whenever we see a child with uveitis, we need to rule out infection. Then steroids, we start with either intravenous or oral. Whenever the steroid is needed for longer term, we switch over to immunosuppressive therapy. I would like to share our experience of the demography, anatomical, neurological pattern of pediatric uveitis over a period of 8 years, to retrospective interventional study of 287 pediatric uveitis cases. The age group ranged between 12 days to 17.9 years. 178 were male, 144 patients were unilateral. In the infantile uveitis, posterior uveitis was the commonest cause. So 178 kids were males, 144 had unilateral presentation. Anatomical site, the posterior uveitis was the commonest presentation in our series. contradicted other reports, maybe because of the referral pattern. In the etiology, idiopathic was the commonest, followed by a parasitic infections. In the parasitic, we saw the toxoplasmosis is the commonest. In the bacterial, tuberculosis was the commonest cause. In the immune-mediated disease, sarcoidosis was the commonest cause. In viral, the non-specific viral entities was the commonest, followed by CMV infection. We had ALL, AML, Hodgkin's, and retinoblastoma of each case. We also had superadded immune-mediated with infections in a case of HLA B27 and TB in one, intermediate uveitis with herpes simplex virus in another case. In the complications, complicated cataract was the commonest complications, followed by the macular scar. Posterior uveitis with infective etiology was the commonest presentations in our cases. A detailed history and thorough clinical examination still remain the most important diagnostic tool. We need to tailor-make the investigations according to the clinical picture. Aggressive and appropriate treatment help to preserve the good vision in this pediatric uveitic cases. Thank you for your attention.
Thank you, Dr. Padmamalini, for your excellent talk. I think what we'll do is I'll let my talk go. We have a very little time. We can have some discussion maybe on any of the talks you have. Here, yeah.
I don't know if everybody is doing the laser in coloboma like you do, because I don't do that. In the first surgery, I always spare the disc and macula. Even in my prophylactic lasers, I don't treat that area. And only for recurrent cases, I treat around that, because I want to spare that area. So my thought process is that there's no break usually in that area. And most of the cases don't recur. And even when they recur, I don't find a break there. But during recurrence, then I treat that area. But I don't know if everybody treats the disc and macular area like Dr. Gopal told. Well, I don't do that, and it works. So I think we can do an RCT for that. Like, do we really need to treat that area, or we can spare it?
Basically, it's a question of a chance, because there's no way you can prove or disprove a communication at that point. And we did have recurrences when we did not treat that area. So if the problem occurs when the macula is just on the border of the coloboma margin, where before the surgery, before the RD, the macula was functioning, and if you treat that, definitely you will lose macular function. Those cases, yes, I would not treat the macular area. I treat up to that point and leave it. But where the macula is already involved in the coloboma, it's not going to make any additional damage. So then I go all the way up to the disc margin, whether to go around the disc or not, because there's no macula, functional macula. Whether to go around the disc margin, I didn't find any problem in treating around the disc margin with the diode laser, because it doesn't harm the nerve fiber layer at all. So you only add to your advantage. You're not really causing any harm to the patient by just treating that extra area. Yes, I understand that if you use green laser and wait for absolute dense white burns, then you have no control over the intensity of burn. But using a diode laser, intraoperatively, there's always a thin film of fluid which protects it like you treat a CSR case. So it doesn't produce a full thickness burn at all. So I don't find any disadvantage in treating around the disc margin, and it's an advantage because you can never be sure there's no communication there. And with the odd case when you have a recurrence, you feel I should have treated it.
Do you buckle these patients?
In majority, I don't. I think I would agree with what he has tried to put across, that when we put an encerclage, we are trying to, sort of stop feeling guilty for a recurrence and trying to sort of treating ourselves rather than the patient's eye. That's why in most of the cases we put encerclage. But I think if we address ourselves logically, in a majority of the cases, probably it was not necessary. We're just putting it because you feel safer putting encerclage. But and in these cases, if you have to sacrifice the lens, and if we are able to do a good vitreous base trimming, and you're treating across the entire vora serrata anyway, then I don't think there's really there's need for it, because the coloboma margin is like this inferiorly. So the part which is actually the original aura, which is not developed now, is not a cause for recurrence at all. It is this border which is a cause for recurrence, and the peripheral aura which is a cause for recurrence. So by putting an encerclage, I don't think really. I use the scissors to cut it.
I think the question of whether to put laser around the margin of the coloboma or not, it depends on whether there are peripheral breaks or not. If there are peripheral breaks, I think there is no need to put laser around the globoma. But if there is no visible peripheral break, then you are obliged to put, because the leakage is probably from the globoma area. What I'm doing is that if the macula is not involved, I usually spare this area. Yes, spare the area from doing laser, and I do laser sparing the macular area. But if the macula is involved already in the globoma, then there is no macular functions. So you have to, you are allowed to do 360 degrees around the macula. This is one point. Regarding sparing the lens in this age group and doing base vitrectomy, I think this is very difficult to achieve. Because once you indent the globe, and it's a soft cataract, then the cataract will, the globe, the cataract or the lens will bulge. And usually it is touched by the shaft of the instrument. If you try to approach the vitreous base from both sides, still there is high risk of injuring the. This is contrary to the adult, where the lens is hard and it is not compressed while you are doing serial fixation, serial indentation.
Yeah, I think basically if you have a patient with a coloboma already developing at the age of 25 years, 30 years, a normal size eyeball, you treat him like any other patient. You don't have to sacrifice the lens. But if you have somebody coming at young age, a microphthalmic eye, where the chances are that you'll damage the lens, as he said, you don't mind sacrificing the lens because your aim is something else. Your aim is to fix the retina, not worry about the lens. Yep.
What strength of silicone oil do you use, 5,000 or 1,000?
That doesn't matter really. So use 1,300 or 5,000. If you have a recurrence and you have a soft eye, you think that you cannot remove the oil for a pretty long time, then use 5,000 centistrokes. Otherwise, you can use 1,300. You remove the oil in about 2 months' time, no problem at all. So I don't think it really matters for the success of surgery what viscosity of oil you use, really.
I totally agree with you, because there is no benefit of using the 5,000 centistoke, because people may think that 5,000 centistoke is provide better tamponade, which is not true. So you are using silicone oil to stabilize the situation reached by the end of surgery. So it is not the silicone oil. It is what you have achieved during surgery, how much time you spend in relieving the traction. And then you inject silicone oil as a temporary tamponade for 3 months or 2 months, and then you remove it. So no matter what you are using, regular silicone or heavy silicone, which I don't like to use it totally. This is another problem. Yeah.
So in some of the patients, I have removed oil within 10 days, especially for my international patients. Some of my ROP patients, I'm concerned they develop cataract or they develop amblyopia. And some of my complicated cases, because like Stickler, some of them really get very high pressures. Recently I had a Wilms tumor Down syndrome patient I removed within a week. So if your surgery is very good and your laser is working very nicely, then there is no reason why the oil has to be kept for a long time. Why we keep oil for a long time are various reasons, like, okay, let us stabilize, let us wait for the inflammation to go away. Sometimes it's the money part, patient cannot afford a second surgery immediately, or sometimes like we are like, okay, let's wait and watch, and I know this patient will need a resurgery or something, so let me wait. But really, if our surgery is very good, then this oil can be removed early. So I believe that I do that, and I don't always keep it for like 2-3 months in all cases. Especially like small babies, when I am putting oil because I know I cannot put gas, because I cannot monitor IOP and child will not remain upside down. So there I am putting it like a default. Whereas if the same surgery was in an adult, I would have put gas. Then those patients I remove within 10 to 12 days. I have not tried. I have seen Dr. Tracy, but I have not. But I have done ILM peeling in ROP surgery in newborn. Somebody had injected Avastin and they developed detachment, acute detachment. within the active phase of the disease. So I did ILM peeling and surgery, and I just did limited vitrectomy and ILM peeling only around the break. And I have shown that video before, and it worked.
ROP, in ROP cases, what we peel from the posterior pole, we do not know what we are peeling. Whether this is a cortical vitreous, or it is a membrane, or it is the internal limiting membrane. I think it is difficult to judge. So even if you believe that you are detaching the posterior hyaloid, which is impossible in these children, you are detaching something else. I don't believe that this is the posterior hyaloid. So in ROP, I do the minimum surgery to achieve a good results and the minimum safe surgery.
No, that is for the fractional detachment. I was talking about regmatogenous detachment. Yeah, it's a reg RD in ROP. Otherwise, we do what you said. We do only core vitrectomy for fractional detachment. Sometimes we have patients who come with reg RD because of, especially after Avastin, or otherwise also sometimes we have few patients where they've presented with reg RD in the acute phase. So there we need to do something more.
In cases with the choroidal coloboma with RD and there is no peripheral break, so any experience of using subretinal trypan blue to find out whether the break is in coloboma or not?
No, as I told you, the simple exercise of just doing a fluid air exchange after you do a vitrectomy tells you what is communicating, what is contributing. And once you know the coloboma is contributing to the RD, you just treat it like what we said. But if you do air exchange and the retina just balloons around the margin and does not flatten at all or doesn't reduce at all, I won't expect it to flatten immediately because the communication between the subretinal space and sub-ICM space can be tiny. It need not be huge. So the fluid cannot be pushed into the vitreous cavity very quickly. But you can see the fluid is reducing but is not flattening. You know that there's a communication. I know the coloboma is contributing. Then you treat it like any other case of coloboma. But if there's a peripheral break and you see that the behavior of the retina tells you that there's no communication, then you treat, as he said, you treat it like any other RD. Just treat the peripheral break. I don't think injecting trypan blue or anything, I mean, in general, you're worried about exposing the RPE to any of these dyes because they have been known to be toxic in vitro studies, right? So even in a case of macular holes, people even go to the extent of covering the hole with a triamcinolone and then putting a dye so that the bare RPE is not exposed to the dye. So in this case, you're trying to inject it subretinally, then the whole RPE is being bathed with the dye. Maybe not the best thing to do.
Thank you very much. I think we had a very good session, and I think I must thank all the speakers for their contribution, as well as Professor Hasan Martada, who did excellent. Thank you very much.